Present a robotic wedge resection of a lesser curvature gastrointestinal stromal tumor and subtotal pancreatectomy for synchronous pancreatic adenocarcinoma. The patient is a 70-year-old male with a surgical history notable for remote appendectomy and recent posterior spinal surgery. Patient was incidentally found to have a 4 by 4 centimeter soft tissue mass on the lesser curvature and a 1 by 1 centimeter mass on the pancreas. Endoscopic ultrasound with biopsy confirmed GIST and pancreatic adenocarcinoma. The operative MRI showed an exophytic submucosal 5 centimeter mass on the lesser curvature and a poorly defined 1 centimeter mass on the pancreatic body. PET scan confirmed no evidence of FDG avid metastatic disease. After discussion at tumor board, decision was made for upfront surgery. Ports were placed using right-sided optical entry, followed by 3 8mm robotic ports and 2 12mm assistant ports to allow docking and upper abdominal access. We begin by dividing the gastrocolic ligament along the greater curvature to enter the lesser sac. The omentum was thickened and the short gastric vessels were taken with the vessel sealer up toward the left crus. This allowed full entry into the lesser sac and exposure of the posterior stomach. There were dense adhesions in the prepyloric region and along the posterior stomach, which were carefully lysed to mobilize the stomach completely. The gastrohepatic ligament was incised, clearing the lesser curvature. The submucosal exophytic mass was clearly identified. The lesion appeared well circumscribed without gross invasion. Circumferential dissection was performed carefully to avoid capsular disruption. The mass was elevated and a robotic stapler with a white load was used to perform a wedge resection of the lesser curvature. The specimen was placed in an endocatch bag and removed from the field. Final pathology revealed a 4.8 centimeter spindle cell GIST with 2 mitoses per 5 square millimeters, no necrosis and negative margins. Immunostaining was positive for CD117 and DOG1 with a low proliferative index. Overall risk stratification was very low. Indocyanine green is administered to assist with identification of the pancreas, as significant peripancreatic fat limited visualization of the gland. The splenic flexure was mobilized and the inferior border of the pancreas was identified. The gland was dissected free along its inferior and superior edges. A retropancreatic tunnel was created at the level of the body and a Penrose drain was passed for control and elevation. Intraoperative ultrasound was performed to localize the tumor and confirm a transection point proximal to the lesion. A reinforced 60mm green load stapler was introduced and the pancreas was divided using a slow compression technique. The distal pancreas and spleen were mobilized and released with the vessel sealer. The specimen was placed in a retrieval bag and sent for frozen section. Frozen section returned positive for invasive adenocarcinoma at the pancreatic transection margin, indicating residual disease proximally. Given this finding, the decision was made to extend the resection to achieve an oncologically negative margin. The pancreatic neck was further mobilized. Additional retropancreatic tunneling was performed and an umbilical tape was placed to provide circumferential control and elevation of the gland. Dissection was carried toward the superior mesenteric vein portal vein confluence. The inferior mesenteric vein was identified at its insertion and divided to allow safe mobilization of the neck. Small venous tributaries to the splenic vein, as well as arterial branches from the splenic artery supplying the pancreatic body, were clipped and divided to fully free the superior border of the pancreas. After meticulous dissection, a Penrose was eventually passed around the pancreatic neck to provide controlled retraction. After confirming adequate proximal clearance and protecting the superior mesenteric vein portal vein complex, a reinforced green load stapler was introduced and the pancreas was divided just to the left of the confluence. Remaining vascular and soft tissue attachments were carefully released, and the extended specimen was placed in a retrieval bag and removed. Final pathology demonstrated a 2.5 centimeter moderately differentiated pancreatic ductal adenocarcinoma with negative margins following re-resection. 26 regional lymph nodes were negative for metastatic disease, consistent with a PT2N0 stage 1B disease. The patient was discharged home on postoperative day 4 and subsequently completed 6 cycles of adjuvant gemcitabine and capecitabine with biochemical response demonstrated by normalization of CA 19-9. He currently is on active surveillance.